Okay, so when we are talking about the neurosensory chapter, we're going to start talking first about the otitis externa, which is that infection in the ear canal. It's also called swimmer's ear. It's characterized by pain and tenderness, and you have that pain specifically when manipulating the outer parts of the ear, so the pinea and the tragus. When you look in the ear, the tympanic membrane looks normal. You can also sometimes just have a foreign body in there. And usually it's treated just with topical antibiotics. It's also called swimmer's ear because it happens when you get water that's in your ear and you don't shake it out, and then it sets up for an infection. And in contrast to that, there's the acute otitis media, which is an infection on the other side of the tympanic membrane. So this blue box in the corner shows you what the tympanic membrane looks like when a child has an otitis media. So you see it's red and bulging here. So you can kind of see the fluid behind the tympanic membrane that's pushing it out. Normally this is more of like a pearly gray color. So kids, particularly young kids, are particularly at risk for otitis media because they have shorter, wider, and flatter eustachian tubes. So the eustachian tubes, they protect the middle ear and they help drain the fluid so that you don't get that buildup of pressure behind the tympanic membrane. So one of the main things that you need to do as a nurse is you need to make sure that parents know to give the full course of antibiotics. Like if an antibiotic course is for 7 days and the kid's feeling better after day 4, you need to make sure that they take that antibiotics for the full 7 days. And this next slide here kind of shows you a kid that's got an ear infection. This is kind of what they look like. They tend to put their fingers in their ear. They kind of rub their ear to side or kind of, they are pretty irritable and they act like they're in pain. Some other sort of signs, in addition to the pain, is like they don't seem to be hearing as well. They speak really loudly. Maybe they're just not paying attention. And if you have chronic repeated ear conditions, this can lead to speech problems or articulation problems. And like we said before on that first picture, the eardrum is really kind of red and bulging. And it's considered chronic if it persists for more than 3 months. So if you have kids that have chronic ear infections, this is where they might think about placing ear tubes to sort of compensate for the fact that their eustachian tubes really aren't able to drain the fluid. They're treated, ear infections, otitis medias are treated with broad spectrum antibiotics and sometimes also ear drops. And then, when the antibiotics don't work, they could do surgical placement of the ear tubes. So all kids are screened for hearing deficits when they're born, but screening is not 100% accurate. Not all kids are born in the hospital. So you need to be on the lookout when you're a pediatric nurse that a baby could have a hearing loss. So some things that you might see is that kind of inattentive behavior, et cetera. They can have acquired hearing loss related to ear infections or other problems. So always just kind of be aware if a kid's not learning to speak normally or is having behavioral problems, that one of the possible causes is hearing loss. And if you're working with a hearing impaired child, it's really important that you get down at their level, you speak to them in clear sentences, and you do your best to communicate with them. So this is a good picture of how you would approach a hearing impaired child. The nurse is at eye level, face to face with the child. So you want to speak in short sentences, and you don't want to do an exaggerated movements with your face or lip, because that can make it harder for them to lip read. So you just want to calm, cool, short sentences right at their eye level so that they can see you. So that's kind of the information on the hearing piece. Also, sensory neuro, thinking about your head. We also talk about eyes. So the two main types of visual impairments are going to be your myopia and your hyperopia. So myopia, nearsightedness, or you see better up close. And then hyperopia is farsightedness, where you see better far away. So usually visual impairments are either described as myopia or hyperopia. And there's also, kids can also have problems with the nerves that control the eye. So there's the strabismus and the amblyopia. So strabismus is cross-eyed, so you can kind of see the eye is kind of not midline, it's kind of pointing towards the nose. And then amblyopia is a lazy eye. So both of these are related to the nerve muscles that control the eye. So the treatment is to put a patch on the good eye. Sounds cruel. So this eye here, if you can see this picture, this is the bad eye. So the good eye is this eye here. So you would patch the good eye, and that would force the brain to use the bad eye, and that would strengthen the eye muscle. So the primary treatment for these visual impairments where they have a problem with their eye muscles is to patch the good eye. So usually when you do it young enough, you can resolve the problem with the patch. You can also do glasses and eye exercises, and sort of the worst case scenario, if it's not caught early and treated, is that they might need to have surgery. You can have infections of the eye. So the most common is going to be conjunctivitis, and you can see this kind of yellowish greenish drainage here. This is very classic for conjunctivitis, and then the red exudate in the eye, or the red, you can see the dilated blood vessels. So you need to teach parents to start in the inner corner of the eye and wipe out to get rid of this eye discharge, and then throw that cotton ball or whatever they used away, because this is very infectious. They do treat it with antibiotics, and it can spread really quickly among children because it is contagious. You worry about it if you start to really get like swelling of the eyelid, or if it looks like the infection is spreading at all outside the eye. Kids can also have it's somewhat of a rare form of cancer, but they actually can have a cancer of their eye. So it's a malignant tumor of the retina. And it's this, when you see these pictures, you see the one that has that whitish yellow glow, that's the eye that has the tumor. So you have this yellowish white reflex that's seen in the pupil. Um, and so it's one of those things that you need to make sure you don't always pick up on everything during when they're in for their well child check. So if the parents ever say anything about the pupil looking funny or kind of being like this weird cat eye look, you need to make sure you take the parents seriously, because this is a type of cancerous tumor that kids can have. So it's usually treatable. Laser coagulation, photocoagulation, and chemotherapy. And usually they can cure the cancer. The worst case scenario is that they have to actually remove the eye, in which case the kid would then have a prosthetic eye on that side. So this next slide has nothing to do with infection, but it's kind of one of those, you always need to know what the most dangerous thing is out there. There's a lot of priority type questions in NCLEX and HESI world. So this is obviously a doll and not an actual patient, but this sudden appearance of fixed dilated pupils is considered a medical emergency. So you're doing neuro exams on your patient, and you see the sudden change in their pupils. So this could be a sign of increased intracranial pressure. When you have pressure that's increasing inside your skull, it can compress your cranial nerves, and then they don't react appropriately to light. So this is what their pupils could look like if they're having problems with their increased pressure inside their skull. So, worst case scenario, increased intracranial pressure can lead to altered levels of consciousness, but a lot of things could also lead to altered level of consciousness. You need to make sure you're aware of them. So you're not having a normal oxygen and carbon dioxide level, having a low blood pressure. And just remember that when you have a fever, that increases your body's oxygen needs, so you can become hypoxic because you have a fever. Certain drugs, sedative drugs or anti-epileptic meds, can cause altered level of consciousness. And having a seizure itself, after a seizure, a lot of times kids are what they call postictal. So they are kind of out of it. They can't speak very well. They're disoriented, confused, they can be sleepy. So this postictal state after a seizure, which is normal, you need to monitor them, but it is a normal process of coming out of a seizure, can cause altered level of consciousness. And then sort of the worst case scenario is the increased intracranial pressure. When you're talking about during a neuro assessment, it's important to always remember the cranial nerves. I don't think that you need to memorize all of the cranial nerves, but you do need to be able to recognize how doing an exam you would elicit different cranial nerves. So you would test the olfactory nerve by having the patient smell something. You would test the optic nerve by having them see something, and the ocular motor by tracking their ability to follow an object. So the ones that are sort of most commonly tested are going to be like your auditory nerve, which is cranial nerve 8, and your glossopharyngeal, that's your ability to stick out your tongue. So to really be familiar with that, you can really tell if these nerves are intact or normal by doing a physical exam and asking the patient to do specific things. And then kind of, the big ones are probably going to be your optic and your auditory cranial nerves that you test. There is something called Reye's syndrome. Has anyone heard of Reye's syndrome? Any parents out there that have been told by their pediatrician not to give aspirin?
Yes, you're part of it.
Yeah, what's the danger of giving aspirin to somebody that's a young child? Do you know? So aspirin, which is in the salicylate family, you need to recognize the name of the family that aspirin is. It's in the salicylate, can cause Reye's syndrome. So Reye's syndrome is an encephalopathy. So it's an inflammation of the brain. So it causes both brain and liver problems. And it can be quite severe. So it's associated with acute febrile illness that in which the parents then give aspirin. So you avoid Reye's syndrome by not giving aspirin when children have febrile illnesses. Most pediatricians tell parents not to give aspirin ever to children, and to always read the medication labels, because you could see aspirin or salicylates in medication that have combined medications that you're not expecting. So just to make sure that you are aware, aspirin is in the salicylate family, and this medication group should not be given to children because of the risk of Reye's syndrome. So there's another condition that you might see in kids. It's called meningitis. So meningitis is simply inflammation of the meninges, which is the fluid film membrane that covers the brain. So it's not actually an infection of the brain, it's an infection of the membrane that covers the brain. But kids can be quite sick when they have meningitis. And the definitive test for meningitis is a lumbar puncture, where they put a needle into the spinal column and they drain some of the cerebral spinal fluid, and they send it for culture. And then, depending what the organism is, they're treated with antibiotics or sometimes antivirals. You can have both bacterial and viral meningitis. There's a couple of different tests to kind of might make you suspicious for meningitis that they can do in a clinic before they do a lumbar puncture. So the one here, the kid lying down, that's the Kernig's. So when you test the Kernig's, when you lift their leg up, they can't straighten it, and it's all related to having increased pressure kind of in their head and neck. And then the other one is the Brudzinski. And when you lift their neck up, they inflexibly draw their knees towards their chest. So neither one of these is definitive for meningitis. Like, you can't say that a patient has meningitis because they had a positive Brudzinski or a positive Kernig sign. But if you're worried about a patient, it's not, you could do these tests in the exam room to see if it would make you more suspicious. So this is something that you would suspect meningitis if a patient had a positive Brudzinski or Kernig sign. So, but the definitive diagnosis is with a CSF. So you can't diagnose a patient with meningitis based on the Kernig's or Brudzinski. So the definitive, you have to send the cerebral spinal fluid for culture. So when they come in, they don't know for sure. They've just sent the culture, but you're going to put them in droplet isolation for at least 24 hours. You're going to do neurochecks frequently because they can have problems with increased intracranial pressure. You need to make sure that you're reporting any weakness, changes in their neuroexam at all, speech difficulties, mental confusion, behavioral problems. Very strict vital signs, intake and output, and then also making sure they have a quiet environment. Things like flashing lights, loud noises, all of that can be very disturbing to somebody that has meningitis. So in addition to meningitis, something that you'll see quite frequently in the pediatric world are kids that have epilepsy or seizures. So there are several things that can trigger seizures. Um, Being overly hydrated, really quick movements, flashing lights, if they're photosensitive, all of that can trigger a seizure in a child. And these things can cause a seizure: infection, fever, epilepsy itself, which is just having a seizure disorder, drugs, or hypoglycemia. So not every child that has a seizure has epilepsy. Sometimes, you can have an infection that causes an isolated seizure, or you have a reaction to a drug that causes an isolated seizure. And then sometimes kids have epilepsy, which is just a condition of having, an identifiable problem inside the brain that causes them to have seizures. So this picture here at the bottom is showing a child that's hooked up to an EEG machine. So this is like measuring their brain wave activity, which is over here. So this is kind of what the neurologist looks at to try to determine where in the brain the seizure focus is. So when they determine a medication they're going to put a child on to treat the seizure, they really want it very specific to where it is, what type of seizure it is, and what's causing the seizure. And they frequently need, multiple tests to really figure that out. So a CT or an MRI and the EEG. And then they're almost always going to be started on an anti-epileptic medication, which is also called an AED. So there's a couple things, I think, this is going to be similar to information that you've had in other classes. There's certain things that you make sure that you're doing when you're taking care of a patient that has epilepsy or a seizure problem. You're always going to make sure the side rails are up, nothing hard around the bed. Heaven forbid they had a seizure and they hit their head. Medical ID bracelet, this is both in the hospital and outside of the hospital. You need to be able to identify that this child has a seizure disorder. And then educating parents that, they might need extra supervision, information about making sure that they're not unsupervised around water. If there's a known trigger, make sure the parents know to try to avoid those triggers. And then medication compliance is really, really important. A lot of the medications, they work when they have a therapeutic level in the blood. So if they're not getting their medication on a regular basis, then they're not going to have that therapeutic level and the medication is not going to be working correctly. There is one of the more common medications out there is a medication called Dilantin. And whenever I'm talking to students about, learning about medications, is to try to remember the things that are different. So Dilantin specifically causes gum hyperplasia or bleeding gums. So you need to educate parents to kind of massage the gums, and that'll help prevent that gum hyperplasia and gum bleeding. Some other things to really remember when you're thinking about seizures is sometimes kids will vomit right before they have a seizure. That's not necessarily a problem. That's just kind of their body's reaction. They vomit and then they have the seizure. And it's not uncommon also to be postictal, which is that kind of that altered state as the seizure ends, where they confuse, they can't speak, they're a little bit sleepy. You do need to monitor them, but it's not necessarily a problem. It's normal to be postictal after you have a seizure. You really worry about a seizure if it lasts for more than 5 minutes. Once you're getting beyond that 5-minute threshold, that's when you're really worried about them able to protect their airway. Are they breathing okay? Are they going to end up with hypoxia or some sort of bad outcome from the seizure if it lasts for more than 5 minutes. So seizures can be really scary. So if you're working somewhere like a school or something like that, you do need to be knowledgeable about it and know when to intervene, etc. Do you guys have any questions about seizures? So there is another condition that you will likely see when you're working in pediatrics, and that's cerebral palsy. So cerebral palsy is caused by anoxic brain injury during birth. So this is going to be like a child that is born and there's an interruption in oxygen to the brain, either during pregnancy or during birth. So they tend to have a lot of medical problems. Sometimes they're mentally retarded in addition to having musculoskeletal mobility problems. So being really spastic is one of the more common problems in kids that have cerebral palsy. They do give botulism. This is like the same medication they give to patients to like get rid of wrinkles. They can use it to manage spasticity. They can also try, levodopa for some of their movement problems. Um, they tend to be wheelchair bound, not all of them. There's a wide range of severity of cerebral palsy, but especially if they're wheelchair bound or if they're wearing braces, you need to make sure that you're doing really good skin care. They can develop contractures just because they're not able to move certain parts of their body. So they often need like braces, and sometimes they need orthopedic or neuro-orthopedic surgery. They can do like tendon lengthening surgery. So, you know, there's a wide range. Like I said, there's a lot of different ways that cerebral palsy can look. Some kids are able to walk with crutches, some are wheelchair bound, some of them just kind of have an awkward gait. So when you're working with kids that have CP, really, really try to establish the best communication. There's a lot of technology out there. They have communication boards. They can teach kids to, point at letters on an electronic keyboard where they can spell words to communicate. They have like, very minimal touch for kids that have limited mobility, for wheelchairs and communication boards. So there's a lot of really good technology out there to help them have as much of a normal life as possible. So, try to your best to communicate with them, encourage movement whichever way they can. Um, and just remember that even if they can't talk, it doesn't necessarily mean that they're not in there. You could really want to try your best to stimulate them, to provide them with distraction and things in the hospital, because they can have normal intelligence, and even if it's a little bit less than normal, they still need stimulation. And then promote socialization, encourage them to be involved in school. You really want them to be able to develop as normal as possible. So just always remembering kids that, could have cognitive impairments, they still have the same psychosocial needs. So they still want friends, they still want to play, they still want to do the things that other kids want to do. So you just kind of have to figure out where they're at and then provide them with games and toys and play, et cetera, that's really developmentally appropriate for them. Um, if at all possible, try to be positive, focus on positive reinforcement, don't focus on the weaknesses. If you have a kid who's constantly told that they're not doing well or they're not succeeding, then they can become angry. So just kind of making sure that you're giving as much support as you can to the parents and trying to help them see the positive side of things. No two children are the same. So individualize your care, develop your care to their maturation and their ability. Try to help them be as independent as possible. And when they're in the hospital, try as much as possible to incorporate their home routines. Always try to emphasize their strengths. Don't generalize, use stereotypes. School nurses are great. If you can get the school nurse involved, should be beneficial to them. And there's lots of support groups out there for parents. So trying to give them the resources that they need. So sometimes we tend to think that we know a lot about a patient just based on how they look. So just because someone has a face that is not symmetrical or looks off, it doesn't mean that they have an intellectual impairment. And sometimes kids that have normal looking faces can also be intellectually impaired. So just kind of remembering not to make any assumptions or judgments based on someone's features. So that's sort of the problems that are specific to pediatrics. We're going to talk a little bit more about like sports and head injuries with sports. Obviously, a lot of kids play sports. So just kind of remembering if they have a head injury when they're playing sports, resulting in a concussion that causes amnesia, that's potentially more serious in the events of a fractured skull or something that they would need more follow-up. So make sure when you're educating parents about sports injuries and concussions to make sure they report any loss of memory. So head injuries can cause all sorts of problems. The most significant being increased intracranial pressure, and it doesn't always happen right after the injury. So you can really have these problems up to 72 hours after the head injury. So you need to make sure that parents are aware to how to monitor for neurological symptoms at home, and that they know that it's not always an immediate thing, that it can happen within 72 hours after the child has an injury. Unfortunately, when we are talking about pediatrics, we always have to think about the possibility of child abuse. And specifically, there is shaken baby syndrome, which is, you know, describes the name of the syndrome describes what happens. So this is, you pick a baby up and shake them. So, depending on their age, they can have like irritability, or they might be vomiting, blurred vision, excessively sleepy. They could have a headache, which could manifest as just being fussy in a toddler. This is a serious problem. It can cause permanent brain injury or death. So you need to make sure that you're educating parents well. If they're frustrated at all, it's always better to put the baby in a safe place and to just walk away than it is to like continually be in the room with the kid that's screaming. So trying to give parents resources, tools, tips for not getting to the point that they just pick the baby up and shake them. So when we're talking about head injuries, increased intracranial pressure, possible brain or spinal cord damage, um, we also talk about posturing. So posturing is never a good sign. There's two types of posturing: decorticate and decurbit. So decorticate, you can see in the picture here, the hands move in like towards a C. And this is also an indication of a cervical spinal tract. So think about the C's. It's either cervical is going to kind of be where you're right between your head and your shoulders is your cervical area. So if you have any damage to that area, you're more likely to posture with your arms folded in like a C. And then decerbate is an E going out, and this is more likely going to be higher up your midbrain, your brain stem. So it's never good when a patient that's had a neurological injury is posturing, but you can kind of see where in the head spinal cord area the injury is based on the position of their arms during the posturing. So increased intracranial pressure, this can be cerebral edema, meningitis. You could have a hemorrhage where you have a massive flow of blood into the brain. There's specific vital signs that are associated with increased intracranial pressure. They're over here on the bottom right. So you do need to know these. These three vital signs grouped together. It's called Cushing's triad. Let's see if I can find the chat. So Cushing's triad is an increase in your blood pressure, a drop in your heart rate, and then a change in your respiratory pattern. So those three things together are concerning for increased intracranial pressure, and it's called Cushing's triad. So this is something that, if you're ever given a priority question, a patient's had a head injury, which one is the most concerning finding? It would be like maybe a drop in their heart rate, because this, usually when you have increased blood pressure, you're also going to have increased heart rate. So this kind of combination of an increased blood pressure with a drop in heart rate with also a change in your respiratory pattern is very concerning. So I'm going to put it here so you guys can kind of remember it. So it's Cushing's triad: increase BP, decrease heart rate, and irregular respirations. And this is what you think about for sign of ICP, increased intracranial pressure. So this is something that you should kind of have in your background of your brain whenever you're asked any sort of questions about priority vital sign changes in a patient that's had a head injury. It's this constellation of changes. So if you're doing neuromonitoring on kids, you're paying attention to their level of consciousness, how interactive they are with their environment, their motor response, is it equal bilaterally, their pupil response. For younger kids, you can pay attention to their fontanelle, if it's bulging or not. Bulging fontanelle would be a sign of increased intracranial pressure. Is there a change in their gait? So there's a lot that you can learn about a patient by doing your neuro assessment. And if you're ordered to do neuro checks, then you're going to be needing to monitor and document on all of these things. So in children, they can end up with neurological problems with a near drowning event. So this is the fourth leading cause of death in children under 19. So it is a significant problem that we need to be educating parents about. Near drowning is defined as survival beyond 24 hours after they've been submerged. So, immediate, you need to be thinking about hypoxia. They haven't had oxygen, aspiration, getting the water into their lungs, and how cold they are. And if they're not recovered within 24 hours, it's pretty ominous. That usually you would see recover within 24 hours if they're going to do okay following a near drowning. So submersion is going to be more than 10 minutes with failure to regain consciousness at the scene or within 24 hours. So you need to make sure that parents know to watch their kids around water, know how to do CPR, know to call 911, etc. And that's the end of the neuro piece. Do you guys have any questions?
I do. I have a quick one.
Yeah.
When we were talking about the eyes and patching of the bad eye to force, or the patching of the good eye to force the bad eye to work,
Yes.
would that be the same thing for the nystagmus where there's the jerky movements? If both eyes are doing it, how would you?
No. So nystagmus is kind of like, you're right. So that's when both eyes kind of twitch back and forth. That you don't treat with patching. It's just the amblyopia and the cross eye.
Okay, thank you.
You're welcome. Does anyone else have any questions? Okay, so we're going to do one more Kahoot and then we'll come back and we'll do the ortho chapter. So let me just give me 1 second to pull up the right Kahoot. Okay, so Sia, I need you to turn your camera back on. Thank you. Okay, let's get started. So why are infants more susceptible to otitis media? The eustachian tube is short, straight, and wide. Infants are almost always lying down. They have increased susceptibility to upper respiratory infections, or sucking on a nipple creates middle ear pressure. Yeah. So this is really the biggest reason is because of their eustachian tube isn't able to drain the fluid behind their tympanic membrane. So as they grow older, the angle changes and they're less susceptible. But when they're infants, it's short, straight, and wide. So a student had a generalized seizure in the school nurse's office. At what point should the nurse call 911? The child is sleepy and lethargic after the seizure. The child vomited at the onset of the seizure. The seizure lasted for more than 5 minutes, or the child is confused and has slurred speech. Yeah, so the biggest thing that you're going to be worried about is the seizure lasting more than 5 minutes. At this point, you're going to be worried about not having good respirations, hypoxia, problems with possible brain damage. So at this point, you definitely need to call 911. So what would the nurse include in a teaching plan about long-term administration of Dilantin, which is also called phenytoin? The medication should be given on an empty stomach. It can cause insomnia. The gums should be massaged regularly to prevent hyperplasia, or blood pressure should be monitored closely. Yeah, so this is the one, this is kind of specific to this medication. It causes that gum hyperplasia. So I remember this because it's a commonly tested medication because the side effect is specific to that medication class. So which assessment finding in a child with meningitis should be reported immediately? A slight drop in blood pressure, irregular respirations, tachycardia, or an elevated temperature? Right. So several of you got this right. So this is trying to get you to think about that Cushing's triad. We talked about increased blood pressure, drop in heart rate. So the red and the blue are not the right answers because Cushing's has an increase in your blood pressure and a decrease in your heart rate. It's normal to have an elevated temperature when you have meningitis, but there's irregular respirations that could be part of the Cushing's triad that you need to report immediately. So the nurse urges the mother of a 6-month-old to get her child vaccinated or inoculated with the Hib vaccine. Why is that? To protect against otitis media, to protect against influenza, to protect against bacterial meningitis, or to protect against skin infections. So good job. Yeah, this one does the Hib. With the Hib vaccine out there, we have less meningitis in the community. So this is the main reason that one of the main reasons you want to make sure people get their Hib vaccine. So which situation would cause the nurse to suspect a hearing impairment? A 3-month-old infant with a positive moral reflex, an 18-month-old toddler who's speaking in one syllable words, a 15-month-old toddler who's babbling, or a 24-month-old toddler who communicates by pointing? So good. Yeah, the one that's going to be concerning is the 24-month-old 2-year-old that's not talking. So the other ones are all going to be normal findings, but really by the time you're 2, you should be speaking in 2-word sentences, me, go, etc. So if you're just pointing to communicate, that's a problem. So what is the best way for the nurse to communicate with a 10-year-old who has a hearing impairment? Let the child's parents communicate for her, recognize the child's will to communicate at a 6-year-old level, use gestures and signs as much as possible, or face the child and speak in clear, short sentences. Yeah, at their eye level, clear, short sentences. You don't want to use gestures as much as possible because that can make it harder for them to read your lips. So what might the nurse explain as a common treatment for amblyopia? To use corticosteroids to treat inflammation of the optic nerve, patch the affected eye to allow the refractory muscle to rest, using glasses that will blur the image for the good eye, or patch the good eye to force the brain to use the affected eye. Right, so this is the one where you're going to patch the good eye and it forces them to use the bad eye. So what information should be given to parents to prevent Reye syndrome? Test children for rise if they exhibit fever, vomiting, and lethargy. Use aspirin instead of acetaminophen when children have a viral illness. Encourage immunization against Reye syndrome, or avoid salicylate medications when children have viral symptoms. Right. So avoid the salicylate, which is the category, that's the family that aspirin is in. Good job. Very good job, you guys. So we're going to take our last 10-minute break. So we'll do a little bit more than 10 minutes. Go ahead and come back at 10:45 Eastern time and we'll do the last chapter. So I'll see you guys in like 12, 13 minutes. Okay, so when you come back to class, go ahead and flip your camera back on so I know you're here. So see, it looks like you're in your car.
I'm just sitting down though.
Okay, you're not driving?
No.
Okay, I don't want to be a hard ass, but you guys, generally speaking, you really need to be in class paying attention. I've had several problems with your camera today, and Sahar, your camera's not on. You need to flip your camera on. Robert Butler, tell me in. I'm sorry, speaking in Spanish. Thank you for turning your camera on. Okay, we're going to go ahead and get started with chapter 24, which is the musculoskeletal chapter. This is a very long PowerPoint, so we're not going to do all the slides, but I'm going to go through and point out the ones that are the most important to you. So we're going to kind of start out here on the fourth slide of the presentation, just kind of talking about when you're observing a child. There's a lot of information you can get just by observation before you lay the hands on the kid. So when you're talking about musculoskeletal, you're going to also do observation of gait. So when kids learn to walk, they're kind of unstable, they're wide, and they kind of waddle back and forth. And that just gets better as they age. So by the time they're 18 months, it's a little bit narrower. They're starting to be more stable. By 4 years, they can hop on one foot. And by 6 years, it's pretty similar to an adult. So sometimes parents will worry about the fact that their kid is kind of squatty and low to the ground and waddling back and forth. So just let them know that's normal when they're starting to learn to walk. When you're doing, either a neuro or a musculoskeletal exam, paying attention to symmetry is really important. So when you test strength, that you test strength on both sides of the body and you document whether or not it's the same. So just always thinking like when you're doing a neurological or a musculoskeletal assessment, that you're doing it on both sides and documenting both sides' reaction to your assessment. When you're talking about musculoskeletal, there's a bunch of different tests. A lot of them are imaging tests, bone scans, CT scans, MRIs, ultrasounds. It's all trying to look at the musculoskeletal system. In specific situations, you might also do laboratory tests. So rheumatoid arthritis or juvenile arthritis and osteomyelitis, you would probably do both of these, which is the complete cell count and the erythrocyte sedimentation rate. The ESR looks at generalized inflammation, and a CBC, you would primarily be looking at the white cell count to gauge infection. And then this HLA antigen test. So sometimes sent if you're worried about an autoimmune or rheumatological disorder. These are not necessarily very common in children, but certainly when you're talking about osteomyelitis, which is an infection of the bone, you're going to be sending both the CBC and the ESR. Not you'll be sending, someone else will be ordering. And there's different ways that you can really assess what's going on. So you arthroscopy, you put a small camera in to see what's going on inside a joint. A bone biopsy, you're taking a small piece of the bone. Traction, I think you guys are probably familiar with traction. This is a way of aligning broken bones. And then casts and splints are used to immobilize a sprain or a fracture. We talk about the RICE, just like in other classes I'm sure you've taken, where you talk about rest, ice, compression, and elevation, which are the 4 things that you recommend when they've had a musculoskeletal injury that's not a fraction. So, you know, if they've twisted their ankle, sprained their foot, whatever, this is what you recommend at home to kind of help them get over it. So when we talk about soft tissue injuries, we're talking about injuries to the tissue that surrounds the bone. So contusion, sprain, and strains. Really, it's important to treat these injuries immediately. And these are the types of injuries that you're going to do the rest ice compression elevation. So it's the tissue around the bone, but not the bone itself. You know, when we're talking about kids, always thinking about how they could hurt themselves, because accidents are a huge problem for kids and a leading cause of death. So thinking about, you know, car restraints, wearing a seatbelt, they should be in booster seats, car seats that are appropriate for their age and height. If they're doing any sort of athletic activity, whether it's riding a bike or playing sports, they should have the appropriate gear to protect them. You know, making sure you have pool fences, window bars so they can't fall out of windows, deadlocks so they can't get out of the house when you're not expecting them to, and then locks on the cabinet doors so they can't get into chemicals. This next slide here goes over different types of fractures. And there are some that I really want to point out that I know that you need to remember. So this first one here that's on the top row on the right, the spiral fracture. So definitely remember that this is associated with child abuse. So if you kind of look at this, you would take like the long bone and twist in opposite directions. So this would be something that an abusive parent or an abusive caregiver might do to a child, and it causes this very, very specific type of fracture called a spiral fracture. So you almost, you know, it's not, when you fall and hurt yourself, you're not going to twist your bone in that way. So that's why this is specific to child abuse, because you could grab somebody's leg and twist your hands in opposite directions to the point that you fractured the bone, and that would cause a spiral fracture. Another one that you're going to see in pediatrics, this is a green stick fracture here, and you can see that the fracture doesn't go all the way through the bone. So it's, you know, this is not going to require surgery. This is like a fracture that needs to be immobilized, and then the bone will heal in, but it hasn't completely transversed the bone. It's a green stick fracture. And then this simple fracture, this is another one that's probably not going to require surgery. It's just the bone is still approximated, the edges still line up, and you can imagine sort of immobilizing that, and this bone is going to form in. Whereas this one here, this compound fracture, so the bone is it's completely broken in half, and it's broken through the skin. So this is a more serious fracture that's likely to require surgery. And it's also really a setup for the patient to develop an infection. You can see like the skin's been broken, so bacteria could get in here and they can get into this bone. So those are, you know, the ones that I know that you kind of need to have in your mind, that you should kind of recognize what they look like, how they might present, and what sort of care you might give them. And this slide here kind of gives you a verbal explanation of the slide before it with all the pictures. So generally speaking, when a child has a fracture, it's painful. There's pain, tenderness. They don't want to put any weight on it. There's swelling. You can also have numbness, which is a concerning sign that you would need to make sure that you report it. Fractures can heal more rapidly in children. Just think about kids, their skeletal system is not fully formed. They're still growing, so their bones heal faster. When we look at some of these, like this is a long bone here. So you can imagine this is called the epiphyses. This is where the growth plate is. So if you have a fracture through this section of the bone, then that bone might not grow normally. So that's here on this slide. It says injury to the cartilaginous epiphyses is serious if it happens during childhood. And that's because it can affect the length that bone grows. So you have the epiphyses in the long bones of the legs. So for example, if you have a femur fracture and you fracture that top part of the femur that fits into the hip, then that femur won't grow as long as the other femur, so they could end up with two legs that are different lengths. So this is something that you worry about in kids because they're still growing. Once they're fully grown, then that doesn't really matter, but this is called the growth plate. So this area here is kind of what signals to the rest of the bone to grow longer. So specifically for fractured femurs, children will sometimes end up in traction. So there's 3 different types of traction that we talk about in this class. You need to remember that Bryant's traction is the one for the little kids. So this is going to be 2 and under. And this is a picture here. You can see in Bryant's traction, their legs are straight up in the air, and then the weights are here and they're hanging off the side of the bed. You don't really see the weights. So this is a type of skin traction versus pin traction. Skin traction, they wrap something around the leg and that's what they hook up to the weights. Whereas with pin traction, they put a pin into the bone and then that pin is hooked up to the weight. So this is a form of skin traction and it's only used in little kids. And it is for a fractured femurs. And sometimes these kids, unfortunately, they have to wear like a straight jacket to prevent them from messing with their equipment. So this is the ideal child in Buck's traction. She looks pretty calm. And then in contrast to Bryant's, Buck's traction is going to be your older kids. And you can see the kind of the basic, instead of the leg being at a 90-degree angle, the leg is straight, and then it pulls the weights in 2 separate directions to realign the bone. And this point here at the bottom of the slide, the most important nursing action for children in any type of traction is performing regular neurovascular checks, and the nurse should report pale or cyanotic coloring distal to the fracture. This indicates poor circulation and restricted blood flow to the extremity. So we're going to talk more a little bit later about the 5 Ps, but this is one of those you certainly need to be paying attention to your priority questions. What's the highest nursing priority? So when talking about traction, it's doing those neurovascular checks as your highest nursing priority. So, you know, there really is very little difference between Bucks and Russell. The main thing is here the leg's a little bit elevated. They use a sling, but they still pull the leg, the leg, it's pulling it in 2 different directions to align the bone. But here they use these slings to kind of lift them up. And this is Russell's traction. And both Russells and Bucks are older kids. The only one that's for the little kid is Bryant's. So general things that you need to remember is these, if they're in traction for their legs, they can never be in a head of the bed higher than 20 degrees. If their head of the bed is more than 20 degrees, that's going to cause their lower extremity that you're trying to pull back into place to be out of alignment. And they're never going to be totally flat. So their heels are going to be elevated a little bit. You need to make sure that you're doing range of motion on the unaffected inner legs. You know, you don't want them having problems, developing problems in their other extremities that aren't in traction. They're going to need anti-embolism. This could be stockings, or it could also be like subcutaneous heparin. The neurovascular checks is your highest priority. Along with skin integrity, you're going to make sure you do good pain medication. A lot of times these kids are going to need constipation treatment because when you're not moving, you're less likely to have your bowels move. And if they're old enough, they should have a trapeze so they can kind of reposition themselves in bed. Some things that you frequently get asked in sort of NCLEX and HESI world. So the weights are always freely hanging. They should never be on the floor. They should always be out of the reach, especially of a child. They shouldn't be able to mess with them. And then you need to make sure that they're in the correct position. So you're not having their feet just on the bed. They should always be elevated a little bit. And these are your 5 Ps: the pain, pulse, pallor, paresthesia, paralysis. These are the things when you're doing your neurovascular check that you need to make sure that you're documenting. So does anyone know what a normal cap refill would be?
Like 2 to 3 seconds, isn't it?
2 to 3 seconds. Yeah. So if it's delayed, what does that mean? If it's like 4 seconds.
It's not getting the appropriate flow down there. There's something going on, a block maybe.
Okay, good. So you need to be able to so you would need to be when they talk about pallor, this is you'd be looking at the color and also the cap refill. And then what does paresthesia mean?
If they're able to feel anything in their in that extremity.
Yeah. And then the paralysis, are they able to move it, like wiggling their toes, etc. So assessing their pulse, you also would want to be able to feel a pulse in that leg, even though it's in traction, you should still be able to palpate the pulse. So making sure that you're aware of all of these things and you're testing it when you're doing your neurovascular checks. This one is not super important. This is just going over, you know, the pin traction. And like I said, the skin, they wrap something around the extremity and they hook that up to the pulleys, versus when they're actually doing skeletal or pin, they're putting a pin into the bone. So this kind of reinforces what we just talked about in terms of doing the neurovascular checks, making sure you're doing good perfusion monitoring. So if they have pin traction, then you need to be making sure you're doing good pin care, so that, you know, there's that added risk of infection because the pin is going into the bone. So making sure that you're cleaning around those pins according to protocol and documenting, looking for any signs of fever, redness, swelling, or increased pain. So osteomyelitis, way back at the beginning of the presentation, we talked about the CBC and the ESR. So this is the condition. If you were trying to determine if a child had osteomyelitis, you would likely send a CBC and an ESR. So this is going to be an infection in the bone. There's usually a local injury. An open fraction is a good indication. That's that fracture where the bone snaps in half and then also breaks through the skin. So when that happens, then you can imagine that's a setup for bacteria to get into the bone. Sometimes they just kind of fall and hit their leg, and it's not exactly clear how they got bacteria into the bone, but certainly an open fraction is a risk factor for developing osteomyelitis. So sometimes, you know, you won't see the infection on an x-ray, so they might do a bone scan if they're trying to rule in or rule out osteomyelitis. This is where they do that, the white cell count you would expect to be elevated, and their sedimentation rate. So the main thing with this one is it takes a long time to treat osteomyelitis. So you need to expect these kids to be on IV antibiotics for like 6 to 8 weeks. So they always go home with a PICC line. And this is going to be one of your anticipatory guidance, patient education things you need to prepare patients that this is really a long time to recover from osteomyelitis. So you need to be creative with diversional therapy and making sure you're staying on top of pain relief, because the affected bone is painful. So other sorts of nursing interventions to think about in terms of the musculoskeletal system is, you know, good cast care. So what can you guys tell me about casts? What should you be teaching parents about cast care at home?
Don't stick anything down it.
Don't put anything down it. It itches, right? But you don't want to be sticking a ruler down there, scratching around. They can't put anything in there. What else?
Keep it dry.
Keep it dry. So they need to wrap it when they take a bath or a shower. Can you dry it with a hair dryer?
No.
Oh,
Okay.
Cool.
so when it's itching, can't you blow like a hair dryer?
A fan is okay,
Fan.
but not the heat.
They had-
So you could turn a fan on and let air circulate around the area. Is it a good idea to elevate the affected extremity? Yeah.
Yes.
So you need to also make sure that parents know how to check the perfusion wherever, you know, if it's in the hand, to check the fingers. Are they swollen? Do they have good color? And it shouldn't either be too tight or too loose. Like if it's too loose, they can move around and not be stabilizing the bone. If it's too tight, they could have decreased perfusion. So those are all things that you need to make sure that parents know about when you're doing cast instructions. So, you know, if at all possible, they should be keeping that elevated up for 72 hours. They can use pillows, etc. And then as a nurse, you need to make sure you're teaching them cast care at home. So there's a couple of conditions that are kind of specific to pediatrics that kids can be born with that involve their musculoskeletal system. So both, there's two forms of muscular dystrophy. There's Duchenne's and Becker's. So Duchenne's is the more common. This is the one that you're going to see most commonly. And they are genetically inherited, but a lot of times parents don't know that it runs in their family. So it's possible to have a kid with Duchenne's and to not know that it's possible that that's going to happen. So you usually really start seeing symptoms between 2 and 6. A lot of times, like, you expect kids to be walking and then they're not. So kids that are clumsy, that fall down a lot, that don't seem to be developing normally from a mobility standpoint, you start to worry about muscular dystrophy. So this picture here, this is called Gower's sign. So this is the position the kid gets into after he falls and he's trying to get back up. And you can see that he has these really you can't really see, but they have hypertrophied calf muscles because they are using those muscles more than normal to try to help themselves get up after they fall. So it's progressive weakness characterized by frequent falling, clumsiness. They can end up with contractures. And then this certainly, if you see this, this is something that you would be concerned about muscular dystrophy. They can also be intellectually impaired, so not have a normal intelligence. And a lot of times they're overweight. So this is a progressive disorder. And there's no treatment. So it's all supportive care. They usually die from like cardiac failure or respiratory infection. So they get progressively weaker and weaker over time. They're almost always wheelchair bound. Frequently, they end up trached and vented. I would say, I don't know, I would say average age of death sometimes probably around age 30. So they can live throughout their childhood, but they just develop this progressive muscle weakness. And like I said, it's supportive care and maintaining quality of life. Even though they have intellectual impairment, everyone that I've had contact with was able to speak and communicate. So you have to be worried about depression, the fact that they're not able to really be on par with their peers and maybe needing some additional psychosocial support. And then there's a couple of disorders that are not genetically inherited, that they primarily affect the legs. So this is going to be your slipped femoral capital epiphysis. This is just displacement of the femur. So think about, the head of the femur fits into the hip socket. So it's displacement of that area. It happens most often during adolescence when they're growing quickly, and you would see like maybe them limping or not wanting to bear weight. And you could use bucks extension or bucks traction to pull the femur back into place. And then another one that is similar is leg cap perthes. So it's also a problem with the head of the femur, but there's not adequate blood flow to the femur. So it ends up affecting the development of the femur head. It's not really clear why this happens. It happens more often in boys. It almost always heals spontaneously, but it can cause permanent problems. So the worst case scenario with the leg cap perthes is they might need to have a joint replacement. Somebody's not on mute.
Jesus Christ.
Okay, so these both the leg cap perthes and the slip femoral capital epiphyses, these are both having to do with the femoral head, more common in boys than in girls. The leg cap perthes is the one where there's not enough blood flow to the femoral head, and it can result in permanent damage to the femur head, where they ultimately have to have joint replacement surgery. And the slip femoral capital epiphyses, this is the one that they can sometimes treat with bucks traction. So I would kind of remember how to differentiate between those two different disorders of the femoral head. So I want to make sure I'm not missing anything. So there's two types of cancers that we see in the bones of children. The first one is osteosarcoma. And in this one, they almost always do like an amputation where they remove the extremity that has the cancer. It's usually the leg. And if it does metastasize or if it does spread, it almost always goes to the lungs. So for this osteosarcoma, you're going to see these pictures of where they've had their leg amputated. And you also need to remember with when they've had amputation, they can have the phantom limb pain. Does anyone know what phantom limb pain is?
Where they still feel like they have pain as if it's still there. It's just the nerve endings.
Yeah, so the nerve endings don't die when they remove the leg. So the pain is real. It's not in their brain. They feel pain. So you need to treat it like you would treat other types of pain. And the other one that we see in pediatrics that's in the bones is the Ewing sarcoma. And it's the same, you know, if it does metastasize, it often goes to the lungs. And if it does, that's a bad prognosis. So both of these are two types of bone cancers that you're likely to see in late childhood, early adolescence. So children can also have arthritis. So this is not like the arthritis that you see in your older adult population. It's called juvenile idiopathic arthritis. It used to be juvenile rheumatoid arthritis. It is an autoimmune disorder, so it tends to have exacerbations and remissions. The peak onset is pretty young, ages 1 to 3. And there's no specific test or cure. It's symptom management. They do frequently get steroids during exacerbations. So they kind of break it down into systemic, which is when they have like an acute fever with it, and then polyauricular or pollauricular. So poly means more. I think this is more than 5 joints involved, and pow is less than 5. And sometimes they also have this bright red eye, which is this uveitis. So they can also have this rash when they have the joint flare up. This is another one where you might send this ESR that we talked about sending with the osteomyelitis. So both the ESR and the C-reactive protein are indicators of inflammation. So you would expect these to be high when the child's having an arthritis inflammation. So depending on the number of joints, it's, you know, polyauricular or powauricular. So this is 5 or more. And like I said, it is a disease that has remissions and exacerbations, and it is a lifelong illness. That's one of the things you have to prepare parents and children for, that this is something that they'll be dealing with long term. And then the powauricular is the main thing, is that it's limited to 4 or fewer joints. And this is the one that's going to be more associated with the uveitis or the problems with their eye. So you want to reduce joint pain and swelling, promote mobility, promote normal growth and development, independent functioning, and then try to prepare them for like managing a chronic illness long term. So advocating for the child, you know, just kind of explaining the as with any sort of autoimmune, it has the periods of remissions and exacerbations. So kids can be born. I think this is probably the best picture, the one with the super cute green onesie with, you see his neck pulled to the side. So this is called torticollis, which is just a shortening of the sternocleidoid mastoid muscle. So it's the shortening of this muscle between his shoulder and his head and neck. So it's associated with breech and forceps delivery. It can be associated with other birth defects like a genital hip dysplasia, but most often it's associated with a difficult delivery. So this is something, you know, you see the kid hold their head to the side. Usually it is just stretching and range of motion. So this is not something that normally requires surgery. This is education for the parents. Worst case scenario, they might need to have surgery, but usually you can do range of motion exercises and it goes away between the ages of 2 and 6 months. So scoliosis, this is a lateral curvature of the spine. Whoops, sorry. So you see this more often in girls than in boys. Frequently, nurses are the ones that are responsible for screening for scoliosis. You screen, you ask the children to lift their shirt up and then bend down to reach their toes, and you're looking to see if you see any lateral curvature of their spine. There's 2 main types, functional and structural. So functional would just means that it's caused by bad posture, and structural, there's changes in the shape of their vertebrae that cause the scoliosis. So you can see problems, it can lead to problems with both their hips and their shoulders. It can also be painful. So it's generally broken down by mild, moderate, or severe, and this is looking at the degree of curvature. So less than 20 is moderate. You would just do maybe physical therapy, but no other intervention. 20 to 40, they would wear a brace. These are some pictures of the braces that the children wear. And then over 40, they would need to have surgery, and the surgery is a spinal fusion surgery. So it's a pretty big surgery. They're admitted to the ICU afterwards, and they can have a fairly long recovery time. You always have to be worried about sports related injuries in children. We kind of talked about this in the neuro, also monitoring for concussion, making sure that they have all of the protective equipment that they need. Certainly kind of being cognizant that certain injuries or certain sports are more likely to cause injuries. And then unfortunately, we're going to talk about child abuse here at the end. I've said before, whenever you're working kids, you have to kind of have child abuse as a possibility out there as something that could be causing problems for your pediatric patient. So child abuse is not specific to any sort of socioeconomic group or any sort of one category of family, but there are certain things that can kind of make it more likely to happen. So social stress, the parental stress, adults who are abused are more likely to be abusive, also having a chemical dependency problem. Sometimes, financial stress, having a really difficult, obstinate child can kind of trigger it. And then also children that are disabled are more likely to be abused, children that have a hyperactivity, and then, foster children and also stepchildren. Sometimes adults are more likely to abuse a child that's not their biological child than the child that's their own. So just to kind of always think about all of the different things that could contribute to the possibility of child abuse. And it's not just physical, it can be emotional, obviously can also be sexual. And kind of remembering the neglect also is a problem, and that's just not meeting their needs without actually causing them physical harm. And you guys need to remember that as a healthcare worker, you're a mandatory reporter, regardless of what state you're living in. All healthcare workers are mandatory reporters. So you need to know how to file a report with CPS. So Child Protective Services, CPS, once a report has been given to CPS, then they're required to visit the home. And then this kind of reinforces that all healthcare workers are mandatory reporters. This one here kind of like gives you some things to think about in terms of what you might look for. If it's hot outside and they're wearing a bunch of clothes, maybe the clothes are put on to help cover up bruises in places of the body that you don't expect, not gaining weight well. All of these things could indicate possible abuse. This next one makes me cry. So, we always talk about bruises in various stages of healing. So you see here on your left, 1 to 2 days, swollen and tender, 0 to 5, red or purple, 5 to 7, green, 7 to 10, yellow, 10 to 14, brown. So just thinking about, the color of the bruise kind of gives you an indication to when the injury happened. So you're going to be more concerned about, bruises in various stages, because that means there's been injury multiple times. So you always want to, when you document bruising, you want to document the color, because that's really important in determining the approximate age of the bruise. So even though we always have to be cognizant of child abuse, we also have to be culturally sensitive and making sure that we're not just assuming child abuse because we don't understand. There's something I know called cupping, where they put cups on the back to try to dry out toxins. So, being aware that it could be child abuse, but also being culturally sensitive. So that is the end of the musculoskeletal. Do you guys have any questions? Okay, so there is a musculoskeletal Kahoot, but we don't have time for it. So I'll post it in the announcements. And then I'm going to give another shout out. Please, please, please go to an exam to review. It will help you tremendously on your exam for next week. And if you guys have any questions throughout the week, just send me a message. If not, then I'll see you guys next week for your test. Bye-bye.
Thank you.
Sure, you guys have a good day. So Lenise, you're gonna stay on with me, right?
Yes.
Okay, I have Christopher. Christopher, do you need anything? Maybe you fell asleep. Okay, there's some people that are still logged on. I'm gonna go ahead and just remove them so we make sure we're being private here. Just a second.
Thank you.
You're welcome. Okay. Let me stop the recording also, just 1 second.